This meeting is now being recorded.
Well, welcome. Again, my name is John Furman. This is the EDS Awareness Series webinar, and I'd like to welcome all of you to our call this evening. But before we get started and introduce our speaker this evening, I'd like to go over our program, the EDS Awareness activities. So we're going to talk about who we are, what is our program, some upcoming events. We'll introduce our speaker for this evening, and then we'll have a Q&A session. So again, my name is John Furman. I run the National EDS Awareness Program based in Cincinnati, Ohio. My daughter, Deanna, runs the Cleveland EDS Support Group. She was diagnosed with EDS in 2008, the same year my wife passed away with breast cancer, and she suffered for 30 years with undiagnosed EDS. So what is our program? We have a national network of EDS support groups. We just started our 70th group. We started in 2012 at the EDNF conference in Cincinnati, Ohio, and we've been a sponsor at the EDNF conferences for the last 2 years. We create support groups. We have videos and articles on our site. We have these webinars every first and third Tuesday at 7:30 p.m. Eastern Standard Time, typically. This program is sponsored by Body Support Store, and you will find over 250 products that were selected by EDSers for EDSers. A brief disclaimer. This presentation contains general information about EDS. It's not intended to be a medical direction as to what it is that you should be doing. You should be contacting your doctor if you decide to change or stop any type of medical treatment. Anyone who is having difficulty tonight should be calling 911 for services.
And upcoming events include our webinars held twice a month, and please don't miss Tuesday, February 17th. We will be hearing from Dr. Epps, who will speak about orthopedic considerations in Ehlers-Danlos, and he was a presenter at the last EDNF conference. And just a reminder that our webinars will be held on Tuesdays for the entire year of 2015. For those attending live tonight, there will be an opportunity for Q&A after this presentation. Add your questions at any time during the presentation by clicking the Q&A icon at the top of your screen. After typing in your question, click the orange button to submit. Our speaker tonight is Jan Dommerholt, and he will talk about physical therapy. Jan is the owner of Bethesda PhysioCare in Maryland, and he has taught many courses at conferences, including EDNF Patient Conference, as well as the Physician Conferences this past year. And he's a recognized expert in PT diagnosis and treatment of myofascial pain syndrome, chronic pain syndromes, and whiplash-associated disorders. His Master of Professional Studies had a concentration in biomechanical trauma from Lynn University, and his doctorate in PT is from the University of St. Augustine for Health Sciences. He is a diplomate of the American Academy of Pain Management and a member of several medical and physical therapy professional organizations. He is well published with several books, approximately 90 articles and 60 chapters in medical and physical therapy textbooks focused on myofascial pain, chronic pain conditions, fibromyalgia, complex regional pain syndrome, and whiplash. And he prepares literature review column on myofascial pain syndrome for the Journal of Bodywork and Movement Therapies. So with that, I am especially pleased to welcome Jan to our presentation tonight. And again, thank you everybody for your patience, and this will be well worth the wait. I'll go ahead and turn over the microphone to you now, Jan.
Thank you very much, Deanne. It's a pleasure to join you today. I'll see if I can bring up my presentation for you. That would be even better.
Right.
There we go.
Okay.
And I believe that you should now be able to see the first slide.
We do.
Yes.
Very good. Well, let's get started. We've waited long enough by now due to technical issues. Again, my name is Jan Dommerholt, as I was already introduced, and I'm going to talk briefly about physical therapy, particularly about exercise, but we can also talk about other issues that may come up in the Q&A later. That's not a problem. So although different types of EDS, the most common one, of course, the classical hypermobility type. There are several other types, as you can see here: vascular, dermatoparesis, arthrochalasia, and lots of others. And even recently, there's lots of other very rare kinds of EDS have been identified in the literature. I must say I have never knowingly seen any of these diagnoses. The majority of what we do in our physical therapy work with people with the hypermobility type. So EDS hypermobility type is the most difficult to recognize in the clinic, although it seems obvious once you know it. But I can tell you that when I teach courses and we talk about EDS, and these courses are usually for healthcare providers, physical therapists, and physicians, the vast majority of our course participants have never heard of EDS, which is, of course, something that many of you have experienced already. There are no really confirmatory laboratory tests or molecular tests or even DNA tests, but it is the most common EDS variant, and it has a very high disability potential, so we really need to do a better job in educating healthcare providers. Interestingly, the percentages, the prevalence of hypermobility varies quite a lot in certain countries. In the US, it's generally considered about 5% of the population. But as you can see here in Iraq and in some very specific tribe in Nigeria, almost half the population has hypermobility, which is very unusual. It indicates that there probably is some kind of genetic marker in those people, and they may have a different genetic makeup than most people in the United States or elsewhere. EDS hypermobility is characterized by not having the typical skin manifestations, the cutaneous manifestations. Skin hyperextensibility is much more common in classical EDS. But you do see changes in how people heal with wound, and even with surgery. If people get sutures, they may not hold so well. But you don't see the typical what's called cigarette paper scars that's common in other types of EDS. But the quality of life can be very poor in adults and in children, and I'll show you some examples of that in a minute. The chronic hypermobility can really lead to debilitating musculoskeletal pain in the muscles and joints, leading to maybe a severe arthritis in later age. And many patients have also been diagnosed with other issues such as fatigue, fibromyalgia, migraines, irritable bowel syndrome, and the list goes on. The problem is that many people with EDS look totally normal. So people, physicians and therapists and other clinicians don't really recognize that there may be something wrong. And that leads often that patients are being misunderstood, and at worst, and we've seen that unfortunately quite commonly, that people are accused of being hypochondriacs and as having psychological problems, and there's nothing wrong, you're just a little bit more flexible and things of that nature. It is very striking that only 10%, now you're wondering what? Well, there we go. 10% of physicians who referred hypermobile EDS patients to a rheumatology clinic, only 10% of those physicians realized that the joint hypermobility was the probable underlying cause of the patient's pain. So it's very, very poorly recognized in medicine. Yet, if you look at studies, and here's a fairly recent studies, the most common complaints of people with hypermobility EDS are musculoskeletal pain, along with several others. There's neurological issues, gastrointestinal issues, very, very common, gastric paresis, for example, but also allergies and influenza-like flu-like kind of symptoms. In another study, 99% of the participants in this study of hypermobility complained of joint pain. 96% had cardiovascular symptoms and 96% also had gastrointestinal symptoms. So the numbers are very, very high, and it is really important that we start recognizing this and coming up with better treatment strategies. So we're talking about physical therapy tonight, and physical therapy, according to the literature, is really generally accepted as a very efficient treatment for most of the musculoskeletal complications. But there are many, many limits. There are limits to how much time you can spend in physical therapy. There's cost. Is there proof of long-term efficacy? Does it really make a difference if you see a physical therapist? And as I said already, the majority of physical therapists, at least in my experience, are totally unfamiliar with EDS. They may know about hypermobile patients, but they really do not get the enormous list of possible complications. Another problem is that many times we're talking about chronic pain, or a better term would be persistent pain, and unfortunately, I hate to admit it, but about 96% of orthopedic physical therapists do not like working with chronic pain patients. This is an older study from 1991, but I have very few reasons to believe that that actually changed. So in other words, about 4% of all the physical therapists in orthopedic physical therapy may be interested in working with people with EDS, especially with the aspect of the chronic and persistent pain. So let's talk about pain a little bit more. And where does it hurt? Well, as I already said, 99% of the people think that joints hurt or feel that their joints hurt. So pain is really widespread. It's not just the musculoskeletal system, but often people have nerve type pain. They may have discomfort in the internal organs even. And that is, of course, a huge problem. 67% of 2/3 reported having constant pain, and only 0.6%, so actually less than 1%, all the people who participated in this particular study did not experience any pain on a regular basis. So it's a big issue. The levels of pain were significantly correlated with higher numbers of symptoms. That makes sense. The more symptoms you have, the more pain you experience. And people really describe their pain as tiring and exhausting pain. You wake up and you're already tired of the pain. Also, a lot of people describe it as an aching pain, which is very characteristic of muscle pain. So, as you saw in the introduction, I specialize a lot in myofascial pain, and I am currently actually doing an extra study. I'm trying to get a second doctorate degree, this time a PhD, and the topic of my research is actually, where does the pain in EDS actually come from? Is it really joint pain? That is where people experience pain. But my hypothesis is that many people with EDS actually have myofascial pain that is experienced in the joints. So myofascial pain basically means that the muscles that cross the joints create contractures or tight bands, taut bands, in my opinion, in an effort to create joint stability. The problem with doing that, and that's not something people do consciously, but the problem with these contracted bands is that they can actually block the local blood supply, leave and cause a lack of oxygen in those muscles. And as soon as you have a lack of oxygen, the pH decreases a lot. And so people have a very low pH in the muscles. That activates the central nervous system and causes an experience of pain. And that pain can be very severe and very disabling. So the literature says that 18% of patients with cervical myofascial pain are hypermobile. In our offices, 100% of EDS patients have a myofascial component to their pain. They all present with myofascial trigger points, but when we press on these points, they mimic or they produce the pain that the patients have been complaining about. So we have no data on that. I hope at the end of my PhD studies to be able to present that data, maybe in a future webinar when we know much more about it. Again, in our office, it is 100% so far of all the patients we see, and we see on average 8 to 10 patients a week with EDS. The literature says about pain, this is one textbook, one of the best known textbooks on EDS, that waiting for the pain to go before returning to physical activity is not going to happen, because inactivity and abnormal movement are the two most important driving forces for the pain. Well, there is some truth to that. When you don't move, you get more pain. So inactivity is I agree. Abnormal movement also can lead more pain, but I'm not so sure that they're really the driving forces. I am quite convinced that the driving force, one of the driving forces behind the pain are actually these contractures and the lack of oxygen to that part of the muscle. Another recommendation was that don't wait for the pain to go away, because that's supposed to be the last thing to go away. And what this author recommended or suggested is that once you get your muscles strong and functional, the pain will go away by itself. That sounds great in a medical textbook, but the reality that I see in my practice is quite different. And the reality is usually that when people are in that much pain, exercise really is not a lot of fun. Exercise hurts. It makes things much worse. And we all know when you hurt, you're really not interested in doing more exercise just to hurt more. So I don't believe that pain is the last thing to improve. We should be ignoring pain and just say, well, just toughen up and exercise through that pain. It never works. So hypermobility EDS, within the context of physical therapy, we see a lot of issues with how people walk. Children with EDS walk with abnormal knee motion. Studies have shown that. They don't bend their knee so much, but they tend to extend the knee too much. We don't really know why that occurs, but I think it has a lot to do with the lack of muscle control over the quadriceps muscles or thigh muscles. In another study, you see on the right side of your screen, the walking pattern was the same in the control group and kids with EDS, but the hypermobile kids had very different forces on the acting on the joints than the control group. So when there's a biomechanical loading, that usually leads to more pain. EDS hypermobility had very different patterns of walking, shorter steps, more time spending on the standing leg when you lift up one leg to take a step forward. And again, the forces on the ankle and pelvis were very different. Here you see one of my patients. She's ambulating with EDS. I've blocked the rest of the video so you can't really recognize her. But this is not a very unusual pattern. The total hypermobility of the ankles. You see hypermobility of the knees, especially the left knee, but also the right knee. There's hypermobility in both hips, and if you could see the rest of the body, there's actually hypermobility in multiple levels of the spine. I would not consider this a normal gait pattern, but it is unfortunately quite common in patients with EDS. So people with EDS also have poor postural stability, so they tend to lose their balance, and quite a few people are a little bit clumsy if you ask them how that works. But I think that also has to do with the muscle weakness and maybe hypotonia, lack of muscle tension, a lack of voluntary control over the muscles, which again may all be related to the myofascial pain component. We don't know that for sure, but it certainly clinically, based on our observations, it certainly looks like that. So another problem with exercise and physical therapy is fatigue. Now, fatigue has been well described in all chronic pain conditions, but also in hypermobile EDS. Again, fatigue is an overwhelming sense of always being tired or having no energy to do anything and always feeling exhausted. So some people say, well, maybe EDS patients have chronic fatigue syndrome. I'm not sure that's really accurate, but we don't really know. But fatigue is very common. Again, that may have to do with having to exert so much energy just to do really basic activities that it feels almost impossible to do anything, and it's much easier to not move whatsoever. Fatigue is a major contributor to disability in EDS. There's no question about it. So we need to get people past feeling always tired. It's a vicious cycle. So people have pain. When you have pain, you can't sleep well. People don't have good deep sleep and no REM sleep, as that's called. And then when you wake up during the day, you're always tired, more tired than your colleagues at work or your other students in class. Therefore, you have concentration problems. Yeah, that has an impact on your social functioning. You may not be able to or be interested in going out with friends or joining friends for a dinner party or whatsoever. That results in a different sense of self-efficacy. You start questioning yourself, can I really do this? No, you probably can't, or you think you can't. And that, again, leads to more pain, and it becomes a very big problem. And fatigue is really an essential part of this cycle. Fatigue is associated with muscle weakness. Yeah, the less strength people have, the more muscle weakness, the more fatigue. And muscle weakness and pain severity are actually very significant predictors of the fatigue severity. Other issues, and you would think, what has physical therapy to do with that? Quite a few people with hypermobility ADS have GI issues, gastrointestinal issues. Unexplained, unpredictable abdominal pain, for example. With bloating, reflux, heartburn, nausea, constipation, etc. We don't really know what the mechanisms are, but I have a feeling that gastric paresis has a lot to do with the connective tissue disorder itself. In people without a connective tissue disorder, when the bowels fill up with fecal matter, they stretch, and once they've reached a certain amount of stretch, we get a stimulus that we need to go to the bathroom. I would not be the least bit surprised that in EDS that stimulus does not occur because the bowels just keep stretching for a much longer period of time. That starts hurting, you get that bloated feeling, and you get constipated. Interestingly enough, in our practice we do a technique called dry needling, and we've now had a few patients when we treat the abdominal muscles that they have seen a tremendous improvement in their gastric paresis and other gastrointestinal issues. We don't really know why that happened, but we've seen it on several patients now, so that's another area of future research. I think that would be well worth a while to explore that. We know that there are connections between the stomach of the skin and internal organs and vice versa, and we suspect that somehow with the dry needling, which basically means inserting a thin filament needle in these trigger points, in these contractions in the muscles, may facilitate, make a connection between the muscle and these internal organs and actually lead to improvements, but we don't really know how it works. A big problem in getting patients in general, not just EDS patients, but in general, getting people to exercise is very difficult. We just started the new year, and if you now go to your local health club, you will be hard-pressed to get space on the treadmill because with all the New Year's resolutions, we are all very active, and this year we're going to really do that. Come back in a month or so, and the gym will be empty again. Studies of patients, you see it here of low back patients, for example, of 64 patients, 73 we referred to exercise, 42 did not even show up, and 28 didn't complete it, 28% never even showed up. Up to 70% of patients do not engage in prescribed home exercises, no matter how simple we make it, no matter what we do. That's an issue. So when we deal with chronic pain patients, and especially with EDS, and we know that activity is going to help you, that you need to work, it is very tricky how we get people to comply and to get motivated in spite of being fatigued, in spite of having pain. So a factor in that is what's called kinesiophobia. Kinesiophobia is really a fear of movement because of past experience. You know that when you exercise more, you're going to have more pain, at least that's the notion. And because you then don't move, because you're afraid of the consequences, you get more muscle deconditioning, you get worse, and it becomes a downward spiral. So kinesiophobia is, as I said, is a form of fear of movement, and it's a bit irrational, but also very understandable because of experience. It is very, very common in most chronic pain conditions, including EDS. Of course, pain is the major factor. I mentioned already, but just saying that, well, just suck it up and exercise and the pain will go away once you get strong, does not seem to work. And it really doesn't matter how severe the pain is. once you're in pain, exercise is not you're not very motivated to exercise. It is strongly related with the severity of fatigue. So we need to figure out better ways to get people to exercise. So what happens? Because people don't get good feedback from their joints, that's called proprioception. Proprioception is the body awareness. Where are you in space? Are you bending your knee? Are you walking on your ankles? Like you saw in the little video, the woman who demonstrated that gait pattern really had no idea that her feet were turning in. She had no idea that her knees were buckling, etc. She had a very poor sense of where her joints were. In her case, as you can see, it affected multiple body segments, impaired posture and balance, and indeed a fear of falling, and indeed a tendency to fall with clumsiness. So in kids, once you're not aware of it, you see all kinds of strange walking patterns. And if we would recognize these things earlier, so pediatricians need to be much more on top of this, you could see often that kids are late with starting to walk independently. Now, there's a huge range of what's considered normal. The kids with EDS tend to walk on their tippy toes much longer. They tend to skip the whole crawling phase, and they're really clumsy in general. So what can we do with physical therapy and exercise? What does the research say? Well, not an awful lot, and that is a big problem. So we're really trying to make a dent in this and educate physical therapists and others to really start looking more at what goes on. So here we see a recent study from 2011 where about a little over 50% of patients with EDS were involved in physical therapy. What did they do? Some exercises, a lot of massage and electrotherapy, something we usually refer to as modalities. People with many analgesics, again, had higher dysfunction. That shouldn't surprise you. If you have more problems, you tend to take more pain pills. What was shown here, that those people who had surgery, only a third was happy with the outcome. But physical therapy, only 63%, less than two-thirds were happy. Now, when I present this to physicians who specialize in EDS, they are very excited and we wish we had that kind of outcome. Personally, I think it is much too low, and I think we can do much better than that. Here's another paper looking at a systematic review of the literature. They looked at lots of articles. They found only 4 that met the criteria. And yeah, people did get better over time. But interestingly, it made no difference if people did joint-specific exercise or a general exercise program, which is interesting to me, and it doesn't make a lot of sense intuitively, but that's clearly what the study showed. So what we tried to do in our clinic called Bethesda Physiocare in Bethesda, Maryland, we recently became aware a couple of years ago of another program in a very unique fitness center called Fitness for Health. That's based in Rockville, Maryland. Well, we joined forces and started a new clinic, Physio Fitness, to really try to better address the needs of people with chronic pain conditions, especially EDS. We know that the current treatment modalities are of limited benefit and mostly treat symptoms, but not really go further. So we know that it doesn't really do the job. We know that multidisciplinary team approaches may be more effective, but I'm also quite convinced, based on our experience with quite a few patients with EDS, that we could do much better, and so far the results have been very, very encouraging. So what do we do? Well, we need to get a very comprehensive physical therapy assessment. We need to make an assessment: how much pain do you have, where do you have pain, how aware are you of your own body position in space, that proprioception, how hypermobile are you, which joints are involved. Not everyone is involved in all joints. Some people only have it upper body, some people more in lower body. What's your muscle strength? Can you produce reasonably strength? Are you afraid to move? And lastly, very important, as I mentioned before, how fatigued are you? Do you actually sleep? Sleep is very important. Without sleep, everything else kind of falls apart. So what we do in physical therapy, we need to educate people. There's a large, and that's part of what we do tonight, education I think is very important. We need to address the pain. I really do not believe that exercising with pain is a possibility for most people. I don't like going to the gym when I hurt, and when you
Yeah, I think we lost the doctor's sound, and I'm not quite sure why.
That's means take undue stress, and you may actually stop blocks or dislocations. The second basic concept that we use, and we're going to go in more detail, is that motion is lotion. You need to learn how to move again within that mid-range of motion. PTs in general, physical therapy, say like, oh, the way we train people is that you need to keep your arm in this position. When you do exercises, make sure your pelvis is in this position, your back is on the ground. We do all kinds of things that we refer to as giving people an internal focus. So we look at your body, we tell you what to do, and talk about movement patterns. If you look at this video, here's an example of that. So you get the picture. The focus is very much on what you can do. But the problem is that although most physical therapists do that, those instructions are relatively ineffective. What you see here is a very different way of exercising, which is what we apply to our patients with EDS. So in the previous video, it was all an internal focus. And the internal focus, I'll turn the volume down a little bit for the video. The internal focus means put your body here, make sure your hips are aligned, that your arm is in this position. Really doesn't work as well as taking the focus of the patient away from his or her own body and looking at something external. So it's like a funky looking machine or a toy or something you can press buttons on. So we're going to show you several totally different ways of training. And we need to establish, yes, local stability in each joint. We need to establish core stability in the whole body. Once we've accomplished that, we also need to work on cardiovascular conditioning as part of the program. Whatever we do, it needs to be in mid-range of motion. We need to avoid end range of motion because that's when the joints are most vulnerable to injury and to pain. So in the fingers, for example, when people hyperextend their fingers or dislocate their fingers, I love silver ring splints. This is not an endorsement for the company, but the fact is they make phenomenal products, as you see here. This is a patient with EDS. She was 18 years old, and every morning she would wake up with one of her fingers so hyperextended that it actually would hurt, and she had to manually put the fingers back. Now that she uses silver ring splints at night, she's actually totally fine and no longer has the issue because she can stay in mid-range of motion. Here you see another patient of mine. This is a violinist with EDS. She wasn't really interested in looking at her whole body, but she was so concerned about her thumb with the hyperextend, and because of that, she could play the violin. Well, we gave her a ring splint. We had to pad it a little bit so she wouldn't scratch the violin, but it solved the problem because now she could function in mid-range of motion for this one little joint in the thumb. So joint stability is another factor. We need to look at joint stability. How do we do that? Well, that's a whole other question. We have a kind of a strategy. We start with individual joint stability. Then we need to groove motor patterns. We need to teach people how to move properly again. And all the way through, you need to become better aware of how you move and where you are in space. That is really training the brain about where your body is. Once you have individual joint stability, we go to whole body stability. Again, same things. Learn how to move better automatically. Learn how to be more aware. Then we need to increase your endurance, not only cardiovascular, but also muscular, so that you can actually sustain the whole day and don't pass out or don't stop functioning by 2 in the afternoon. Strength training is a major factor. We can do specific endurance training. We can also, again, train proprioception through strength training. And lastly, agility training. Now we need to learn how to move again properly. Motion is lotion. I love this picture. I found it online. An 88-year-old figure skater who said this: you grow older. If you don't move, you won't move. Well, you don't have to grow older. If you have EDS hypermobility, if you don't move, you won't move either. So why it's so important? Well, if you don't move, you make the problem worse. If you just lie in bed, in young adults, it was shown that they use approximately 1% of muscle mass every single day. We all know when we get older, we lose even more percent of muscle mass, and some elderly people can lose up to 5% a day just to changing hormonal levels. It is quite amazing, and it's mostly prevalent in the muscles you need the most. Those you need used to sit up, stand up, pull up, and move around. If you spend one day in absolute bed rest, you may need 2 weeks to recondition yourself to get back to normal. So it is very important to move. The question is, how do we move? When you have hypermobility EDS, lever arms, you can see in these two pictures, these two little videos, are disastrous. It will lead to dislocating joints, and this is not really appropriate to really, really far advanced patients. So we do it quite differently, and we look a lot at the research of Dr. Gabriella Wolf. She's a researcher in Nevada, and she's really spent a lot of time like, how can we learn the best? How can we get our skills the best? And she's actually found out and confirmed again and again that what we pay attention to is actually has a major impact on how you learn to get stronger, how you learn to move. And that individual focus on their own body, like put your hand here, put this, avoid that, really doesn't work as well as an external focus of attention. And that's what we do with our equipment. So the accuracy and quality is really gets much better when you have focus on something outside yourself. Here you see one of our piece of equipment. This is called a Jacob's ladder. Most people would just let patients walk up this thing, and the colored bands you see are not there. We added those to our machine. And if you listen to the instructions, I will stop talking. You could actually hear that the instructor, the physiotherapist, or the trainer, or gives the patient instructions which color to touch. And as you look carefully, each little band also has a number on it, 1, 2, 3, and they're totally random. So not only does she have to do the physical activity, and she determines how fast the machine goes, she's also cognitively challenged. She has to pay attention. And what we've learned from the research from Dr. Wolf and others, that if you challenge people by an external focus and give them a cognitive challenge, people learn much quicker and do much better within mid-range of motion. We never told her what to do as far as range of motion. She just does it automatically. So here you see another machine. It's called Makoto. This is originally designed for kickboxing. Well, we can apply this very carefully, and if we don't want people to get challenged to reach out as she does sometimes, we can put something on the floor that you need to step over before you hit out these lights. Again, what you see, we never talk to our patients like, make sure you do it in mid-range of motion, make sure you do this, make sure you do that. We just work with the patient, make the conditions such that she automatically will do it properly. Why does that work? Because now she's training her brain to function in mid-range of motion. The internal focus would tell us, no, don't reach so far, make sure you keep your hands next to your body and say this and so, and take the fun away from the activity. Here you see another piece of equipment that originally was developed for Formula One race car drivers. Again, very simple. We can knock out any of the lights if they reach with too much. She has to touch these lights and then they go off. Oh, she's pretty good at that. You'll be amazed how hard it is. But again, it is very much an external focus of attention, and that's much more effective to learning how to move, how to train your brain about your body's position and to learn joint stability. And it's a lot of fun. So Dr. Wolf develops a hypothesis, which he fancily called constrained action hypothesis. But that's basically what we said. If you give patients exercises, and in EDS I think it is so important, if you give them an exercise when you have to knock out a light or kick something or hit something or hug something, the desired outcome, joint stability, better proprioception, everything, the other things I mentioned, almost becomes a byproduct. Our patients don't focus on, I need to keep my arm in mid-position. No, they focus on, how many points can I score? How can I do better than last time? We never have problems with people not showing up because I've had too much pain, I can't come to PT. Our patients love coming to this center. Now, I understand that not everyone has centers like this available, but with a little bit of imagination, you could do all this without any equipment. You can create an external focus and make it a lot of fun to do. sitting in a gym and pushing weights on a weight machine is boring for most people. And not only that, it also creates a lot of leverage, a lot of lever arms on the joints that may not be the best thing ever. So here's another machine. Now this is fairly advanced the way she does it now. But again, all these machines are computerized. We can also program it a little different so that you only have to step on it, for example. We can do any of these things at a very basic or very advanced level. We recently had a bunch of NFL players here, and they had to work very, very hard. But because we tap into the brain's capacity to figure out how to do, the result is automatic. The results are absolutely amazing. We've had patients go through this clinic who dislocated their hips. We had a 12-year-old girl who did this all the time. And after just a few weeks in our program, she stopped dislocating her hip because she developed sufficient muscle strength. So movement efficiency, how well do you move, is not only what happens within the muscle, but also how all the muscles connect together. Here you see another machine where you use little light sandbags, or you can make them heavier if people can do it, and you need to move automatically in the right body dynamics and body mechanics. It works phenomenally well. So this has been studied to sports, golf, basketball, volleyball, soccer, even dart throwing, American football, as I mentioned, and also high jumps. It has been studied in patients with Parkinson's disease, with patients with a stroke or a CVA, or cerebral vascular accident, autism, and balance issues, as you can see this gentleman, and in pediatrics. And we don't really have any data available to how well it works in Ehlers-Danlos syndrome, but we are in the process of setting up studies to actually study this approach in Ehlers-Danlos syndrome as well. Clinically, I can tell you that this has been one of the best things we have to offer to our patients. We just started this last year in the second half of 2014, so we don't have a lot of data yet, but I'm very optimistic that we can actually prove that using this external focus is very, very beneficial. Another toy that we use, and I call these things toys, there's a whole body vibration. This is called a power plate, and it's actually vibrating. Now, this is fairly advanced. This is a little less advanced. By standing on it and vibrating the plate she's standing on, the muscles that patients with EDS have difficulty contracting will automatically contract. There's quite a lot of research that whole body vibration has a major impact on body strength and muscle strength. She's fairly advanced, of course. Not everyone will be able to do that in the beginning, but this is another very useful intervention. So the key is that we believe that with exercise, if you combine fun, training with cognitive challenges, you do much better. Here's a variation on the previous piece. You see the teeny little LCD screen in the middle of the board that she's working on. We can put little mathematical equations in there. 5 plus 3. Well, you have to answer that while you hit these lights. If you look carefully, it's a little bit off the screen. She's standing on a fairly wobbly surface. That will focus and help her automatically get better ankle joint stability, knee joint stability, and even hip stability. Her brain will learn automatically. We know that this kind of approach is an effect on how well you feel about yourself, how well you think you can solve problems. It also reduces anxiety, also reduces depression, and reduces that kinesia, phobia, or fear of moving. You're moving without knowing what you're doing, and it is so much fun. So we know that there are an awful lot of benefits to this. It increases serotonin, all the chemicals in your brain. Brain-derived neurotrophic factor is a chemical that the brain produces that makes the synapses in the nervous system much better connected, and you do much, much, much better. So I am quite excited about all this. It is a fun way to go. So with that, we kind of get to the end of what I wanted to share with you tonight. I'm certainly able to answer questions once I hit the next button and go back to the presenter screen. I really appreciate the opportunity to share some of these ideas with you. If you're in a place where people don't have such a fancy center, the key is learn how to move in mid-range of motion while you're having fun. That can be accomplished in so many different ways. You don't need any equipment. We have treated patients with EDS for years without this fancy equipment. I'm very happy that we have it now, but it is not essential for the training program. So with that, I'm coming to the end of my presentation. I hope that this was useful to you and helpful. So I'm going to close the sharing ability here and go back to the screen.
Yes, thank you, Jan. It was an incredible presentation. And if you open up the Q&A list, you should be able to read the questions from the live attendees and answer those verbally for us if you can.
I'll be happy to do that.
Thank you.
I see one question that has more to do with the technicalities of the meeting. That was already addressed, I think. I have a question here from Matthew, and I will only mention your first name, so if you still want to add questions, I'm not going to reveal your last name to the whole world if you don't want that. I have a question from Matthew. It says, my first meeting with a physical therapist, unfamiliar with EDS POTS tomorrow. What information should I bring or what questions should I ask? Well, apparently, Matthew, you already know that the physical therapist doesn't know much about EDS, but I would ask first how willing the physical therapist is to learn more about this. Next, you can provide the link to this presentation or others. There's a lot of information available. The support group has a lot of information. The Ehlers-Danlos National Foundation has a lot of information. There actually is a brochure you can download for the EDNF website about information for healthcare providers, and I would start there. I hope that answered that question. If you scroll down a little bit more, this is a question from Julie, and she says, like, new issues continue to surface on a regular basis. The latest I'm dealing with here is peripheral neuropathy in my right foot. I think this is due to sciatic nerve compression. Do you have any suggestions? Well, that's a tough question, Julie. Peripheral neuropathy is an increased sensitivity of the nerves, usually in the legs or arms. That is a neurological condition that does occur sometimes with EDS. It could be from sciatic nerve impression, but that probably is not really peripheral neuropathy, although it may feel the exact same. If it is due to nerve compression, again, and physical therapists with manual therapy skills should be able to give some relief. Try to find out where do you have the nerve compression. This could be due to compression in the buttock area, it could be in the low back area, but it could also be in the leg itself. Look for a physical therapist who knows about neurodynamic mobilizations. That's a fancy term for freeing up the nerve from its surrounding pressure areas. Sometimes massage or even trigger point therapy in the buttock muscles, particularly the piriformis muscle, will help. If it's really true in peripheral neuropathy, you probably need to see a neurologist and see if there's anything that can be done with medications. There are some medications that address this, but it is not very, very effective as far as it can certainly take the edge off, but it is a problem. The next question is a question from Kelly, and Kelly is a future physical therapy student with EDS, hypermobility type. She was diagnosed over a year ago, and the question is, if possible, I would deeply appreciate it if I could address ways for people with EDS to avoid hurting themselves in routine activities. That is another great question. Initially, I think it's very difficult to not hurt yourself because it is so easy to overdo it. It is so easy to overreach. It's so easy to move way out of mid-range of motion because you're so hypermobile. So the first thing I think to learn is that range of motion does matter. That as long as you keep hyperextending your knees, your elbow, your wrist, your fingers, there will be a most likely consequence. Now, for a long time, when children are hypermobile, that doesn't really bother them. But many of our patients, by the time they get 10, 12 years old, it starts hurting. And the party tricks of being able to do strange things with your body and being very hypermobile are now can only be done at a cost. So education is the first thing to do. And secondly, I would really encourage you to try to continuously remind yourself, okay, how can I do this? If you want to open a door, for example, let me just try to be practical. If the door is heavy and you don't know that, and you reach with your arm extended to the door and you try to pull the door and the door is heavier than your strength, you may dislocate your wrist, your elbow, and your shoulder. So instead of reaching out and not being in mid-range of motion, maybe you need to put your elbow against your body, approach the door a little closer, hold onto the door handle, move your whole body back, so use your whole body strength rather than the strength of your arm and shoulder to move the door. But it is a tricky question. I'm not sure that I can address any possible way in this webinar. We talk a lot about this. What are the things you can do? First thing is how can you be aware of things. A lot of my patients, when they first come, they may sit on their feet in the chair. Well, that's far from mid-range of motion, and it puts their hip joints, the knee joints, and the ankle at much greater risk. So it's a lot of awareness in how to do that. So let's move on to the next question. This is a question, I just scrolled down too far. A question from Colleen. Thank you for addressing physical therapy. This has been one of my most difficult treatments to engage my 4 EDS teens, young adults in. They are reluctant to try and stick with the program due to fatigue and pain. They have daily rib subluxations. Let me see, I just scrolled down the frame. That they go back in only for a few seconds. We've considered prolotherapy and bracing, but all docs feel physical therapy is the safest. It's very difficult for them to try any exercise with dislocated ribs. That is, I would totally agree with that. That is quite tricky. The bottom line is still that you need to get the muscles that stabilize the trunk much, much stronger. That may mean you have to start at a very basic level in a range of motion that does not dislocate the ribs. That's very difficult. And indeed, you said, but she also writes here, I don't want to push them too much. Will it really do any good for their ribs? Well, it's a good question. It can help. It is not easy. That is definitely not an easy thing to do. Physical therapy should be really, really slow and not push them too far. It should be within pain limits. As soon as you dislocate ribs, it's probably quite uncomfortable. But it is a big problem. I don't believe that prolotherapy will help a lot if it's on multiple ribs. Prolotherapy is an injection of basically sugar water that causes an inflammation in the ligaments and makes the ligaments that cross the joints a little bit shorter. If it's on 1 or 2 joints, that may work fairly well. But if it's on multiple joints, I do not think it works very well. And in EDS, one of the problems is because the connective tissues are so loose that when the injections are done with the prolotherapy, it tends not to stay at the place where it needs to go. It tends to diffuse. So that's one issue why prolotherapy does not always work. We're going to the next question. This is a question from LB, just initials. And he or she says, I recently started seeing a physical therapist who practices integrated manual therapy. After practicing many years more traditional, she does not employ any typical conditioning, does not give me strength or other exercise. Her diagnosis is different. Our sessions are more like craniosacral therapy. I don't understand the theories, and my therapist does not talk much about it. I feel better after these treatments, about as much as I did with other treatments. One second, I lost the thing again. Question is, are you familiar with this? Does it work, or should I return to other forms of therapy, treatment? IMT, integrated manual therapy, doesn't really seem like a bona fide therapy. It's just gentle hands-on by the therapist. Well, what can I say? I am not really familiar with the term integrated manual therapy. That can mean a lot of different things. I would think that in the initial phase of treatment, these hands-on therapies are very, very helpful. We do the same in our clinic. We don't do integrated manual therapy per se, but we do a lot of manual therapy techniques to decrease the pain that people experience. But if that's the only thing you're doing, I don't think it's going to work very well. I believe that certainly for EDS, there really are 2 phases to the program. One is a pain management phase in reducing the pain levels so that you can actually be more successful exercising. I mentioned the 12-year-old girl that we had with a dislocating hip. Before she started our exercise program, I worked with her and did a lot of work on the muscles around the hip to decrease her pain so that we can even consider doing exercise. So in the long run, hands-on therapies it may feel great, but I don't think it will get you much beyond feeling great for a very short time, and then the pain basically comes back. Let's see what else we can do here. I'm trying to scroll down, but somehow my screen seems to be frozen. That's a problem. My screen is frozen. I'm not sure what to do about that. Any suggestions from the organization?
I can read the questions, or I can get Deanna to read the questions for you. I think Deanna would probably be in a better position to do that. So, Deanna, I'm going to let you go in and read the questions. Are you on the call now? Or I got to make sure she's unmuted. Deanna, are you unmuted?
Yes. Can you hear me?
Okay. Yes.
Okay.
So I think we were down to, you already did LBs. Did you do Cheryl's after that, Doctor? Do you recall? Okay. I have one here. It says how to treat ITB syndrome. I have pain referred from my tailbone area to my outer knee. I can barely walk. That's from Shelley. I think we lost the doctor. We'll see whether he can connect back up.
I can hear you okay, but yeah, I did lose his audio.
Yes. Okay, well, we'll see whether we can get back on the audio. So it's really been a techie problem tonight.
Yeah, we apologize. The server for the meeting company that we use to host the meeting was having trouble today. So that may be what's going on right now. Thanks for your patience.
Okay, I think I'm back on. Am I back on?
Yes, you are.
Okay, I'm terribly sorry. Again, there's lots of issues with the connectivity. I got kicked off the website. So I'm very sorry for that, but it looks like I'm back on. So let me scroll back to the questions we were on and see if I can answer a few more. And now everything is working. My screen totally froze up and then the website just quit before. So let me go back to, here's a question from Cheryl. Let me read it first. It's quite a long question. I have a teen with EDS who keeps getting tendonitis from simple tasks in the feet, shoulder, and wrist, and attacks, maybe walking, getting dressed. Exercise like recumbent bikes makes it dizzy. Suggestions for strength training, maybe light biceps curls that won't cause further injury. Any kind of videos that we could do on YouTube, etc., etc. Well, the question whether your teen really has is whether she really or he or she really has tendonitis. That's a diagnosis that makes it very, very easy because as soon as people have joint pain, pain around the joint, the diagnosis is made very commonly. I'm not always sure that that is correct. If you take, for example, in the shoulder, a lot of people get diagnosed with the tendonitis of the biceps muscle, the upper arm muscle that crosses over the shoulder. And when you really look at that carefully, very commonly it's not the biceps tendon that hurts, but the muscle right next to it, which is called coracobrachialis muscle. So I'm not convinced that a lot of people with EDS really get tendonitis all the time, but much more likely scenario is that they have pain in the muscles as they cross the joints. That is an issue, and of course it comes back to probably not being conditioned enough, not having enough strength in the muscles to make it happen. The exercising with a recumbent bike and make it dizzy from it is a bit of a concern because then I would wonder, is there a POTS component to this? Because it really shouldn't cause dizziness. Even for 5 minutes of biking on a recumbent bike should not really do that. As far as exercise for strength training, light bicep curls are perfectly fine within mid-range of motion and with very light weights. I much rather actually prefer maybe things that you can wrap around the wrist rather than weights in the hand because sometimes weights are too heavy and put the wrist at risk as well. I am not sure of whether there are many videos on YouTube for EDS that I'm not really positive of, but that would be something to explore. I am not personally familiar with that. Okay, next question is from Shelley, and she says, how to treat ITB syndrome? I assume that she's talking about iliotibial band syndrome, because she then says, I have pain referred from my tailbone area to my outer knee. I can barely walk. Well, the iliotibial band is a fascia band. It's a tight band on the outside of the upper leg. It goes from the basically from the hip area to the just past the knee and attaches at the lower leg right below the knee on the outside of the leg. So the ITB syndrome, iliotibial band syndrome, is a problem where the IT band tends to be too tight and gives a lot of issues and therefore pain. The IT band is very, very critical. You cannot live without an IT band. You wouldn't be able to stand up. As soon as you would stand up and lean a little bit to the side without an IT band, you'd fall over. So it's a very important structure. The IT band is connected directly to the gluteus maximus muscle, the major buttock muscle, one of the strongest muscles we have in the body. And sometimes when the gluteus maximus muscle is not doing well because maybe of hip problems, it puts too much tension on the iliotibial band and can cause irritation anywhere along, but usually in the outside of the knee. So one thing to look for is like how tight is the gluteus maximus muscle? Are there bands in there that hurt when you palpate them? The other muscle that's important is the vastus lateralis muscle, and that's the muscle on the outside of the leg, on the upper leg. That muscle is pretty closely connected to the IT band and can also give problems along those areas. But I would get a professional to really look at that, either a physical therapy or a physiatrist or maybe a chiropractor familiar with soft tissue injuries. The next question is from JH, and family used to live in Bethesda, Maryland, where I am, according to this note. And but the question is a little bit off topic. Can myofascial pain cause anxiety? What areas in the body are most prone to myofascial pain? The answer is yes. Any kind of pain can cause anxiety because it feeds into it. Myofascial pain probably even more than other types of pain because myofascial pain is experienced in the brain, is processed in the brain in the same region where our emotions are processed in the so-called limbic system, periaqueductal gray, if you really want to get technical. And so many times the areas of muscle pain where your brain processes muscle pain are very similar to the areas where your brain processes emotions and anxiety. So yes, and part of pain in general, not just myofascial pain, is the fear of, is it ever going to go away? Will I ever get better or not? I mean, that in itself can cause enough anxiety that, yes, all pains can cause anxiety. What areas are most prone to myofascial pain? That can really be anywhere, but I think that the upper quadrant, the neck and shoulders, and upper back are probably the most prone. Question from Catherine, what's the best way to overcome post-surgical muscle atrophy? One, a lot of patience, because it takes a long time. When the slide I showed before, that just a day of rest and not moving at all may take you 2 weeks to get back to normal function. The same thing is true for post-surgical muscle atrophy. You've been inactive, you had surgery, you're in the hospital probably for a couple of days, and then at home. The best way is to be patient and to very slowly start training again. That may initially be with isometric exercises. If you have fancy toys like the vibration plate that we had, the power plate, that may be very, very helpful. If you don't have that, it's really a matter of slowly starting to exercise again and trying to strengthen the muscles. I would do that with a healthcare provider though. Next question from JH, not sure if the same JH as before. I mentioned that the quadriceps is used less in walking with typical EDS patients, and JH says that it was suggested that that's my tendency. No, JH, the research clearly shows that this is a fairly common issue in hypermobility type EDS, and that may be partly because the knee tends to be overextended, and therefore the quadriceps doesn't really have to do that much. The second component is, and not just for the quadriceps, whenever a joint hurts, which is again 98% of EDS hypermobility patients, whenever a joint hurts, any muscle that crosses the joint will be automatically turned off a little bit. So it won't function as much. So therefore, you're not going to use it as much if you can't really activate it. You're going to use the muscle less and rely more on leaning into your ligaments, like hyperextending the knee and trying to get through life that way. But it's not a good way to deal with it. Next question from Janie, how to deal with a rapid muscle fatigue. Limited use of hands body due to weakness, fatigue in the muscles. I cannot progress in PT as I get too tired to keep apart and even get out of bed. What do you advise? Yeah, this is a very common problem. I touched on it briefly in my lecture, my talk. Fatigue is really the number one reason of disability, or one of the number one reasons of disability in EDS. It is a problem. It really is a problem. You can't really stay in bed. If you stay in bed, everything gets worse. So one of the first things is to really try to get out of bed. If it's because of pain, maybe you need to get on some kind of pain medication from a physician. They don't always work well in EDS patients. They get poorly absorbed, so that is a problem. But that would be the first thing probably to look at. And the physical therapy, I think, needs to be very gradual. Again, you need to have a lot of patience. A lot of our patients, when they start exercising with us, it may take them over a year to reach any kind of functional status. So it's not something that has a quick fix. It's going to take a lot of persistence, a lot of support of other people, of partners, of friends to really yes, we can do it. You may even get someone to go with you to physical therapy to make sure that you get out of bed. Do as much as you can to get past that. Next question from Cheryl. Do you think gastro issues related to mast cell activation syndrome disorder? Yes, that is a good question. It's a little bit out of my area of expertise, but in the EDS consortium I am part of in the Baltimore, Washington area, we recently had a lecturer who presented on mast cell activation. This was a physician from the National Institute of Health, and they were clearly direct correlations between mast cell activation and gastrointestinal issues and other issues. So the answer is yes, there is a link, but it's not something I feel comfortable talking a lot about because other than the one lecture, I really don't know much about that. Next question from Catherine. If I walk on the treadmill for a mile or two, within 2 or 3 hours, I stiffen up and pain and fatigue increases. Is there an explanation for this? Yeah, I think the explanation is that, or possible explanation is that you are not conditioned well enough to do this. That your body responds almost like in an alarm system that says like, hey, this is not good. I'm going to stiffen you up. I'm going to make everything tighter. That is a fairly typical thing also of myofascial pain. So you may actually have a lot of myofascial trigger points that may need to be treated a little bit. A few weeks ago, there was a webinar on dry needling by one of our distinct colleagues. That may be a possibility. We use that quite a lot. But it's really, I think, a matter of stiffening of the body. Now, why the muscle stiffen? There are a lot of biochemical reasons why that can happen. That's probably a little bit beyond this lecture. But I would see someone for it to say, like, why are my muscles stiffening up so much? Because it usually is the muscles that stiffen up, and as a result, the joint stiffen up, and you get pain and fatigue. A question from Jennifer. How do I know if the pain associated with exercise is causing wear and tear in the joints? How do I know how much is too much? That's a very good question. Muscles are supposed to protect joints. So it's a bit of a catch-22. If the muscles are too weak to protect the joints, that's where you're going to see wear and tear. That's not going to happen quickly. Most people, younger people with EDS, if they have surgery, like arthroscopy, and people actually look into the joints are usually in really, really good shape. The problem is later in age, when the muscles continue to be weakened, but just by aging get even weaker, that's really when you see a lot of wear and tear in the joints and probably greater likelihood of arthritic changes and pain. So I don't know how old you are, Jennifer, but if you're anywhere probably under 50, you should be able to generate enough force and muscle strength slowly but steady without really a big risk of causing wear and tear in the joints. As long as you stay within that mid-range of motion, I think that is critical. The more you go to extreme parts of the joint, the worse it gets and the bigger risk you take. Next question from Cheryl. Could someone come without a doctor referral to physio fitness for a short amount of time for setup for patient routine to do back at home? Or could a local PT call and consult with staff at physio fitness? Physio fitness is the physical therapy clinic where we do all the exercise stuff. In the state of Maryland, you do not need a referral to see a physical therapist. So yes, the first question, can you come without a doctor referral? That's definitely true. That's not in all states like that, but Maryland has a total open access to physical therapists. I am more than happy to consult with other physical therapists if usually email works better than calling. I travel an awful lot. I travel all over the world. As a matter of fact, was in Ireland yesterday, and I will be in India next week. So I do travel a lot. So calling me is not that easy. But email works very, very well. And if you go to our website, you see our email. It's actually very easy. It's my last name, Dommerholt, at BethesdaPhysiocare.com. We'll get you there, and I'll be happy to, willing to talk to other physical therapists or other healthcare providers about this. I have limited time, so I hope not everyone will take me up on that because then it's going to be a while before I can follow up on that. Okay, the next question, and I think I'm back to the same issue. I can't move my screen anymore. I see the beginning. I am 20-year-old EDS hypermobile male with chronic heel pain. Tried PT, special orthotics, different types of, and that's all I can read. And I cannot scroll anymore. The screen froze up again.
Deanna, can you pick up on that?
Oh, there it goes. Well, it just moved again. It just jumped forward. Okay, that's great. That's interesting. I don't know how that happened, but Have you had other EDS patients with this type of chronic heel pain? The answer is yes. I asked the rest of the question is the person has had different types of shoes, cortisone shots, taping of the heel, stretching, many other things. A very common cause of chronic heel pain is tightness of the calf muscles. And many people don't look for that. Many people look at the source of pain, of the area of pain, but not necessarily look at the source of pain. So what's very common in EDS is what's something called referred pain. I already alluded to that. I think that a lot of the joint pain, but heel pain falls under that as well, is often the result of referred pain. So the source of the pain is really not in the heel, most likely, but most likely in the calf muscles. The gastrocnemius, the most superficial calf muscle, but also the soleus muscle, which is right underneath that. The very common source is the deepest calf muscle in the back of the calf, the posterior tibialis muscle. But even the long flexors of the toe, the flexor digitorum longus muscle, can cause this. So I would really look at the calf muscles. You could do this yourself. If you squeeze your calf muscles in different areas and it's extremely painful, that may be something that is part of the problem. So next question from Sukrit. I keep straining muscles almost every time I increase activity. I have had 30 plus injuries and I'm unable to walk more than 3 minutes a day for the last 1.5 years. Can you suggest very basic exercise to help walking? I have seen 15 PTs over the last 4 years and almost always end up with more issues afterwards. Well, that's a sad statement about my profession, I must admit, but the question is, why are you straining your muscles? So that would be the first question I think that should be answered. I'm not sure that I can do this without taking a look at you first. But there must be a reason why that happens. It may be a catch-22 that the muscles are so weak that they just can't do anything, and therefore you would have to start at an even lower level of activity. But 3 minutes of walking a day is not a lot of activity. So I'm not sure I can answer that question without actually either taking a look at your medical records or taking a look at you yourself. That's a little bit difficult to answer. I know that's not really an answer that makes you happy, but I'm not really sure that I can do better than that. Cheryl has a question. How can you apply the whole truth? The objective of PT is to kind of get rid of you, to be honest, in the best possible way of the word, of course. We'd like you to become totally independent and to be able to do everything you need to do at home once you have the skills to do that. Yes, you could do a lot of things with an external focus, rather than always going back like, oh my gosh, where's my body? Am I doing this? Am I doing that? Once you reach a level of proper awareness, it should really go automatically. You can apply to anything you want. You can say, well, if I'm in the kitchen and I need to do something in the kitchen, let's say I need to reach something in the cabinet, what are you going to focus on? You're going to focus on, my gosh, my shoulder's really going to hurt now, this and that, so and so, or you're going to focus on, I need to open that cabinet. Looking at the door and focusing on the door handle is already an external focus of attention. That sounds funny maybe, but that really makes a lot of sense. If you dance, for example, rather than focusing on every single step like you do when you learn dancing, like ballroom dancing or something, if you focus on the music, if you focus on the rhythm and just start moving along with it rather than focusing on your body, that can really help. So things like that, I think, fit into an external focus of attention. Moving to music. Trying to catch the beat of a song that you really like and trying to move to that. That's an external focus of attention. So next question. There are a lot of questions, I must say. I didn't quite expect that, so that's great. Question from Lynn. Do you find patients tolerate therapy for a time and can have good results, then the opposite occurs and spasm contractions occurs? Chiro, osteomassage, IMS, myofascial. Wonder what is occurring. These reactions have been increasing over many years. I currently told to stop strengthening exercise and work on stretching muscles following application of heat. Wow, that is a very intriguing question to me. Because as a rule, I do not really believe that people with hypermobility type EDS should be stretching muscles. And why do I say that? Your joints are hypermobile, so when you try to stretch, you only make the problem worse. So I strongly believe, and I think there's a good reason for it, I strongly believe that joint stiffness, increasing joint stiffness should be the focus and not stretching. If you stretch your muscles, well, you may be stretching muscles, but you're probably too hypermobile to really stretch muscles. So what's going to happen, you're going to stretch the capsule of your joints, which will lead to more hypermobility. So I am not really convinced that stretching is the way to go. The same thing applies to manipulations. We see quite a few patients who've had joint manipulations, spinal manipulations, either by the chiropractor or by the physical therapist, because the physical therapist or chiropractor will look at someone's spine and say, oh, you're hypermobile, you're moving too much. Oh, with that midsection in your spine, that's really not moving enough. We need to make it move even more. I don't think that makes any sense. I think that stability, stiffness is the key rather than hypermobility. So when part of the spine doesn't move properly, I am happy and I wish that the rest of the spine would do the same thing. Stretching, in my opinion, is really not a good thing to do. Yes, people do relapse at times. That does happen. There's lots of reasons for that. You may not have slept very well in a couple of days. You may worry about something. That's one possibility. You may have overdone it a little bit, and then your body will respond by saying, like, hey, we're going to slow you down a little bit. I'm going to throw some contractions at you. I'm going to put some muscle spasms, and that immediately hurts. So there's lots of reasons why you would relapse. Typically, or you may not have exercised for 2 weeks. Like you say, you know, I took a little break, I went on vacation, or you may have the flu, you lie in bed, you couldn't do anything. So now that you start exercising again, maybe you need to start at a slightly lower level to avoid this from happening. But bottom line, stretching muscles is generally not something we would recommend for people with EDS hypermobility type. Question from Jennifer. By focusing on the external and not providing instruction, how do you correct if the patient isn't doing an exercise properly? If their stance isn't good or they are hyperextending during the activity? That's a great question. In the ideal world, we should set up the exercise in such a way that you automatically do it properly. Well, that doesn't always happen, but we do provide a lot of instruction. We just don't provide instruction about the body. So honestly, we can't always exclude that. If you, let's say, one of the activities you saw in the video, putting these little sandbags in and picking them back up, if you just lean forward from your hips because you can and you can reach down that far, we will have to give you instructions about your body. It's not totally black and white that we never do that, but for most people, we really don't have to. And certainly in the center that we have available, and I must give the owner of the clinic the credit for developing this. I had nothing to do with the development of this center, but got in much later in the game and saw the opportunities for EDS. So, yeah, we do need to give some activity sometimes, some advice and instruction, like hyperextension is never a good thing. If that's what you do, we may alter the activity a little bit. That would be my first choice, to make sure you don't hyperextend. Next question, also from Jennifer. A lot of the exercises seem to involve quite a bit of movement. How can you tailor the activity to someone with, for example, POTS, dysautonomia? Yes, the videos you saw were all done by our staff, and yes, they do move a lot, and these people do not have EDS, hypermobility type. In that sense, the videos are a little bit misleading. That's absolutely true, and I don't have any better videos than that, so that's why I use these. We can set up the activities at any possible level. All that equipment is computerized. Well, something I did not show in the presentation is we have a laser room, very similar to Mission Impossible laser room. If you want to get the diamond or the big prize, you have to wiggle your way through all these lasers that move up and down and side left and right and all that. At the most basic level, we can just put a few laser lights across the floor and someone steps over them. At the most advanced level, it is so hard that I can barely do it myself. So any of the activities can be done at a very, very basic level of movement. So yes, we can modify that very easily. I did not show that, and maybe I should have, but I'll take that as advice for the next time I do one of these things. Question from Donna. I have hypermobile knees. Occasionally my knee will bend backwards a bit too much, resulting in a Baker's cyst, which is painful. I try to remind myself to be aware not hyperextend, but sometimes it happens anyway. How do you feel about the knee brace with stops to keep the knee from hyperextending? Great question, Donna. A knee brace with stops is kind of the same thing as a finger splint, like the ring splints that I showed in the presentation. And I think that's actually not a bad idea. If you can stop the knee from hyperextending, just like we do with the finger splints, that'd be great. I would be very wary of knee braces that immobilize the leg, though. That would not be good. If you can still flex the knee, bend the knee as within reason, as much as you need to do functionally, but you just can't hyperextend, I'm really not against that. I think that's not a bad thing at all. Julie, do you know of PTs in Boston who have this type of equipment? Excuse me. When looking for a PT, what do I ask to get this type of equipment? Well, I know of a clinic in the Boston region that is exploring getting some of this equipment, but that's currently not in place yet. I am not really sure if there's anyone with this kind of equipment. There are several clinics who may have one or two of the pieces, but I don't know anyone in that region. You could potentially contact us at Physio Fitness and ask for Mark Sickle. Mark Sickle is actually the owner of the program that we borrow space in. He may know the answer to the question, but I personally do not know that. Next question from Matthew. We're moving on. We still have quite a few questions left. I'll try to do them as much as I can. And we probably will have to stop around 10 o'clock Eastern Standard Time here. It's now 9:39, 9:40, just for time's sake. The question from Matthew, how would you approach an EDS hypermobility patient with C-spine compression fractures unrelated to trauma? I would probably need to know a little bit more about that. What the reason is of the compression fractures, how old is the individual, if it's an elderly person, that could have a lot to do with osteoporosis or osteopenia. Spontaneous C-spine, cervical spine compression fractures are quite unusual, so I'm not really sure where that would come from. I would want to make sure that I knew why the spine has compression fractures. If they're not related to trauma, that's the most common reason, before I would even give any kind of advice on that. I saw in this public chat on the site that Mark Sickle's name was misspelled. It's actually Mark, M-A-R-C, and the last name is S-I-C-K-L-E. That is correct, but that's okay. He would not know the difference. Question from Kelly. There you go, corrected already. Any advice to sleep without dislocating shoulders? Maybe a type of pillow with arm support. Part of the problem when you sleep that you have no control over your body position. And so problems often happen at night. Just like in the presentation, the young lady who dislocated her fingers every single night. When you lie on your back, the arms are actually drooping down, and therefore there's a lever arm on the shoulder and often on the elbow as well. So yes, having pillows on either side of the body where you rest your arms on, so they should be relatively firm pillows. They can't be too fluffy so you still sink into them. Maybe a way to go. If you sleep on your side, having something to put your arm on is very useful. Many patients can't sleep on the side because of dislocating shoulders, so lying on that side would actually hurt. So I don't think you need to get a particular pillow. I would just get a fairly firm pillow. Certainly if you start sleep on your back, that'd be great. If in the middle of the night you turn over and sleep in a different position, there's very little you can do to control that. A question from Monica. Are there some of the exercises you presented that are not recommended to those of us with POTS? That's a good question as well. I think the issue with POTS is to avoid triggering the autonomic nervous system by making quick changes in movement. Some of the videos, as I already commented on, are fairly high-level exercises. I would definitely not start with that if I knew an EDS patient also has POTS, which is, of course, very common. I would start with much lower pace exercises and avoid these very quick changes as far as not triggering autonomic response. The next question from Denise is similar to that. I have a question from those patients who also have POTS. Do you start these patients in supine, then to sitting, then to standing? In some individuals, and most people, I would really prefer to do things three-dimensionally and really go slow. Don't avoid quick turns, avoid quick up and down movements, but the better you make the exercise, the more you make the exercise functional that relate to real life situations, I think the better it will be. Question from Kelly. What are the best exercises to maintain muscle tone? I see that I need to avoid free weights with arm exercises. Free weights are not necessarily wrong for arm exercises, but it depends a little bit how hypermobile you are, Kelly. If you're very hypermobile, it is very difficult to avoid the joints from subluxing or dislocating either. If you're not that terribly hypermobile and you can do the weight training in a limited range of motion, let's say for upper arm, for biceps curls, or there's actually another muscle underneath the biceps that you train even more, you could start, if you put a weight, let's say, on the table, have your elbow already bent a little bit when you pick up the weight, and then limited range of motion, reducing the risk that you're going to dislocate your joints. That could work very, very well. You can also use flexible rubber bands, like TheraBand is one of the brand names. But those, you would have to do the same thing, really stay within mid-range of motion. The problem of weight machines, if you go to a gym, is that they're really not designed for EDS patients. And you probably need someone else to come with you to get the weight in the right position so that you can be in joint range of motion. Let's say for the biceps, again, the most weight machines in gyms require you that you pick up the weight, your arm fully extended, elbow fully extended, and then move your arm up. Well, that wouldn't work for you, so you would have to have someone else, a spotter or maybe another EDS patient, if you work out as a team, with that person using both hands, full body, gets the weight in the right position, you can pick it up and then start exercising. Question from Kim. Is aquatherapy a good type of exercise for EDS? Aquatic therapy is one of the absolute best things for EDS. I wish I had it available in my region. There are a few therapeutic pools in our region here, but none really that specialized in what I would consider to be really good. If you have an aquatic therapy program, that is phenomenal. The nice thing about the water is that it's very supportive, and the buoyancy of the water actually applies a little pressure on the joints, and you can easily avoid hyperextending. So yes, you can do a lot of exercise in the pool. Water is actually what's called isokinetic, which means that if you apply force in water, let's say you move your arm at a certain speed with a certain amount of force, the water always matches that force, and that's called isokinetic. So it's easy to not overdo it in the pool. We don't have that available here, but if we had a pool next to our clinic, I would use that a lot. Very good question and good advice. Shelley has a question. How do we explain these workouts to our patients currently? It sounds good, but hard to understand. Yeah, the problem with a brief presentation is that you can't really cover everything in this short amount of time you have. I think that without having the equipment available, it certainly is still possible to do all this. But you would have to be more creative in setting it up for either a home program or in a clinic that doesn't have these toys. But that can be done. I think that giving people exercises where they automatically do that, you could do it with a ball, for example, tossing a ball on a rebounder, on a little mini tramp almost. You can do the same thing just by creating the environment where you stay within that mid-range of motion automatically. Again, it's not always 100% possible. You may have to resort to internal focus of attention every now and then. That's perfectly fine, but it requires a lot of creativity on the part of the clinician. Question from Chris. Do you have fun suggestions for neck stabilization exercises? The current doctor has said my neck is very unstable and only prescribed putting palm on forehead and pressing head against hand. Yeah, Chris, that is an isometric exercise, so there's really not much movement. That may be okay to start with, but it's not very useful in the long run because isometrics really don't translate into function as much as we would like to think. The question is, how unstable is the neck? If the neck is really, really unstable, you probably can't do neck stabilization exercises that are going to make a difference. We see quite a few patients who have very significant instability issues, and frankly, a lot of these patients end up getting cervical fusions, which is not great, because the risk of a fusion is that if you fuse two or three vertebrae, or sometimes even the cranium, the head to the spine, so there's like a cranial cervical fusion. It works in the short run. In the long run, we don't really know what happens. We've had a few patients who had fusions a few years ago, and basically you can't move that part of the neck. But the problem is you're still going to rotate your head. You're still going to look over your shoulder, so the part of the neck that did not get fused starts taking more of the load and becomes a bigger problem, which means that at some point in the future you may need another fusion. We've had a few patients who've had multiple fusions over time, and that's a big problem. But if the neck is really unstable, it is a really big challenge in what to do. I am not so sure that you can overcome that because most of the exercises we do are for the large muscles. Even pressing your head against your head mostly stimulates the larger neck muscles, the sternocleidomastoid in the front, the big neck muscles in the back, but it doesn't really lead to joint stability of the vertebra, because for those you would have to activate the deeper paraspinal muscles, the multifidus muscles, and that's not that easy to do. So I don't have fun suggestions for neck stabilization exercise if the neck is very unstable, as you said it is. If it's not as unstable, I think it needs to be incorporated in whole body exercise and avoid, again, the end range of motions. Next question, I have a question from Elisa. Dyspraxia, how does that play a role? I see it on the slide, but you didn't mention it. Is speech dyspraxia, the muscles in the mouth, affected? I didn't mention everything that was on every slide. You're right. I skipped through a few things for time's sake. Dyspraxia is basically difficulty figuring out how to move. Let's say if you need to walk from point A to point B, but there's some let's say your living room, there's some shoes lying on the floor, you may have difficulty avoiding stepping on them, and then instead of stepping over them or going around them, that may be an example of dyspraxia. A silly example, but nevertheless a real world example. So dyspraxia is really the sense of clumsiness, that you just don't move comfortable. Speech dyspraxia, yeah, it is possible to have that in the mouth muscles, but that's usually not called dyspraxia. That's different terms for that. But yeah, I don't see much trouble with muscles in the mouth with Ehlers-Danlos patient, but that is, of course, possible. Question from Anne. Do you have any suggestions for a 9-year-old in school for gym class? And how does POTS factor into the physical therapy? I think we've addressed the POTS issue to some extent. POTS needs to also be managed medically by physicians who know what to do, and there are not many physicians who do that. That's the problem. Suggestions for gym class. Well, it depends a little bit on how hypermobile the 9-year-old is. The 12-year-old girl that I treated that I mentioned before, I actually wrote a letter to the school, to the principal of the school, but also to the PE teacher to avoid any kind of contact sports. And the teacher was very happy with the advice, did not know much about EDS, but clearly could understand it. And the 12-year-old, she's probably 13 by now, was exempt from all those kind of activities. But you do need to do something in PE. So there are lots of things that kids can do, but in general, the schools can't really accommodate the needs of an individual patient. So I would just communicate with the teacher, maybe with the principal of the school, to really explain this is what it is, these are the risks, and that's why my child really can't participate in these things. Can we figure out something else that would still meet the needs of a PE class and the needs for a kid to move? I think communication is the key to that. Question from Deborah. Our experience with EDS is that it requires ongoing physical therapy concurrent with home exercise. Insurance companies now have lifetime caps on physical therapy, in our case around 60 sessions. This is unrealistic for people with EDS. What role can physical therapists play in promoting change in such dysfunctional insurance practices? Yeah, that is a great question also. I mean, many people have really good questions. What can we do with insurance companies? Insurance companies are a big problem for most chronic pain conditions. Recently, I think it was in New York, the courts ruled that chronic conditions cannot be a reason to stop physical therapy. Nevertheless, insurance companies do have policies, depending on what kind of policy you have, that limit physical therapy. 60 sessions lifetime is kind of crazy because most people will have more sessions than that. You may break your leg at some point. You may go skiing and tear your ACL. You may have a stroke later in life. And for all these conditions, including EDS, it is very unrealistic to put limits on physical therapy. What role can physical therapists play? Well, the Physical Therapy Association actually does a lot of lobbying in Washington, D.C., and also at the state level, and trying to convince politicians to change these issues. The Ehlers-Danlos National Foundation is very interested and works very hard on providing education. In the end, the way it stands now, I believe that the law is in effect for chronic pain conditions, so it could go under that perhaps, but it is a big problem because insurance companies and pharmaceutical companies really rule medicine, including physical therapy. And I don't try to be cynic about it, but it is a fact that insurance companies are less concerned about you, the patient, or me, the patient, in my role as a patient occasionally, and much more concerned about meeting the needs of the shareholders. And I don't want to turn this into political talk, but it probably needs to go through the government to force people to change that. That's not a very likable concept, and a lot of people have issues with that. People already have lots of issues with the Affordable Care Act, and it's problematic, but it brings up a lot of other issues that are a little bit outside the scope. As a physical therapist, I can tell you that I always argue with insurance companies, and I must admit, rarely am I successful in convincing them otherwise. So it's not a great answer, but that's the reality. Question from Elisa. I was able to see my chiropractor who uses a Pro Adjuster tool to adjust you. It worked wonderful, broke up muscle memory, which for headaches and spasms due to joint stability was wonderful. What are your thoughts on this? And chiropractic care in general? Let's start with the last question, chiropractic care in general. I think with any healthcare provider, whether it's a chiropractor, physician, or a physical therapist, the quality of the care depends a lot on the individual provider. There are great chiropractors, there are terrible chiropractors, there are great physical therapists, and there are terrible physical therapists. So I would really check out the individual clinician and see, okay, do you have a genuine interest in seeing me as an individual? Or do you schedule 15 patients an hour and you don't have time for me? Do you schedule many patients an hour or 3 patients at the same time and I'm just one of the many who does exercise in the gym? That probably wouldn't be the best chiropractor or physical therapist to go to for EDS. As far as the adjuster tools, there are different ways to use that. Some chiropractors use the adjuster tool to release muscle tension, and you may use them directly on trigger points. There are actually a few studies on that. That use of the adjusters tools, I think, is great. Adjusting the cervical spine or the thoracic spine in generally, I am, as I said before, not a big fan of, because I think a little bit stiffness in the spine is probably not a bad thing. So I hope that answers the question. Here's a question from Deborah. As we're moving on, we have a few more minutes to go. I'm afraid I won't be able to address all the questions. There are just too many good questions. Are there any weightlifting exercises that are particularly risky for EDS? Oh yes, absolutely. Any weightlifting exercise that pushes the joints out of a stable position are dangerous, are risky. Any weightlifting exercise that uses weights that are beyond the capacity of the patient are very risky. So yes, that is a big problem. I do think that weightlifting can be great, but it needs to be really done very carefully and really within a safe position. Next question from Leah. How do I stop my elbow from subluxing and also my sternum and my ribs always hurt and feel out of place? How do I stop my elbow from subluxing? The key to that is to make sure that the muscles around the elbow, the biceps, the brachioradialis, and the triceps in the upper arm, and the wrist extensors who also cross the elbow in the forearm, need to get as strong as possible. That's one. Number two, you really need to avoid any kind of activity or position where the elbow is hyperextended or at risk from hyperextending, because that's when it will sublux the most. You need to avoid carrying things in your wrist, like heavy bags, shopping bags that could pop out, that create a kind of a torque, a leverage on the elbow. So a lot of it is preventative stuff, but then also you need to really work on strengthening the muscles around. That's the only option you have left to deal with subluxation. The sternum and ribs, we kind of addressed that before. That is a huge problem for which there really is no good answer. If the ribs indeed dislocate at the sternum, it's very, very tricky. There are no really good taping techniques to stop that because the forces are too much. I don't think that prolotherapy really works. I think good posture may help, like really getting your trunk better aligned so that there's less stress on the ribs and less sense of that the ribs actually work. Breathing may be a good thing if you're very much a chest breather, where you put a lot of more stress on the ribs by moving them 16 times per minute. That's about how much we breathe. That would give you over 20,000 opportunities to put stress on these joints per day. That may be another issue, but that's a really, really tricky question. It's 10 o'clock, and I just saw the message. Thank you, Dr. Dommerholt, for the presentation. So I'd like to thank you for the opportunity to share some thoughts with you. I'll be happy to answer other questions, but don't please email me all at the same time, because as is, I already get 300 emails a day, and I will try to answer them all, but that may be a little tricky to do. So thank you very much. I appreciate the opportunity to share my thoughts with you tonight. Good evening.
Thank you, Jan. Wonderful presentation, and on a topic that a lot of us are really challenged with finding, appropriate information for how to treat EDS patients. Everybody's chiming here about how they appreciate you answering their questions and really enjoyed the content that you presented tonight. And we wanted to extend an invitation to you, to come back again if you're able to, and give us some more details about some of the more specific research or EDS information that you're currently pursuing.
That's going to take a while before we have data on that, but I'm happy to repeat this at some point in the future and see if we can answer other questions. That'd be perfectly fine. It's a great
Thank
format
you.
to do this in, so that's great.
Great. Well, we appreciate everyone attending, and we still have quite a few on the call. So we had a very good response, and even in the fact that we had a little problem getting started. So the video will be on our site tomorrow, along with the doctor's slides. And there's contact information as well, information about this facility. So please come back and check that out. We'll be sending out emails and notifying people as well. So again, we're sponsored by Body Support Store, so please go out and check out the store. We have about 250 products, different types of braces and pillows and pads and other things that could be helpful for you. So do check that out. Our next webinar formally is going to be on February 17th. We have a pending one on February 3rd, but the official one's on February 17th. So please check our website. If you'd like to be given announcements or emails regarding upcoming webinars, please request the free report on our site. So again, appreciate everyone who hung in there, and have a good evening. Thank you.
Thank you. Good night.
Night.